A very good evening and warm welcome to all the dignitaries present here. I am Momita from Clirnet, serving as the allocated physician assistant to ensure a seamless experience. Clirnet stands as India's most relied upon digital platform offering a multitude of imaging services exclusively for doctors. It is with great pride that Clirnet serves as the digital partner for this event, hosted by the Oncology Integrated Society, and the focus of today's session is role of palliative care in ICU for cancer patients. So now, without any much delay, let's begin today's session, for which I would like to invite Dr. Dipti Chaturvedi ma'am to take over further. Over to you,
Yeah.
ma'am.
Hello and welcome all to this yet another episode of Cancer Webinar Series. It is a matter of honor and proud privilege to host this webinar from the aegis of Onco Integrated Research Foundation, supported by Dr. Chaturvedi Cancer Hospital, Gorakhpur, and Clirnet team. Today we have with us a very learned, talented, astounding, brilliant speaker, Dr. Ayush Garg, Associate Professor from SRMS Bareilly, who will be talking on the palliative care in ICU of cancer patients. Presiding over the webinar, we have with us Dr. A.K. Chaturvedi, who is a renowned senior oncologist and owner of Dr. Chaturvedi Cancer Hospital with a record experience of treating cancer of about 40 years, and who has been the past, present UPARI and has been co-guide and training about and many awards and publications to his credit. Questions will be put in the chat box so that they can be discussed at the end of the meet. Now, before the beginning of the session, I would like to call upon all our dignitaries, even in the non-faculty link, for lighting of the lamp and remembering God and goddesses of light and knowledge. It takes away all the ignorance of darkness and bestows upon us brilliance, energetic lights of knowledge and wisdom with each upcoming webinars. Now, please start with the lighting of the lamp.
Om Saraswati Namo Namah, Ma Saraswati Namo Namah, Vidyadayani Namo Namah, Hansavahini Namo Namah. Om Saraswati Namo Namah, Ma Saraswati Namo Namah, Vidyadayani Namo Namah, Hansavahini Namo Namah.
Without any further ado, I would like to call upon Dr. A.K. Chaturvedi, the renowned senior oncologist, to come forward to take the chair and take over the proceedings further. Dr. A.K. Chaturvedi, are you on the line? You are muted. You are muted.
Thank you, Dr. Deepti, for inviting me. Now, today's topic is very interesting. Palliative care in ICU. As such, palliative care for the cancer patient is very important because palliative care is focusing on improving quality of life, relieving the sufferings, pain, discomfort of the cancer patients, which allows patients and their caregivers to take part in the planning of their care. Approximately 17 million people are diagnosed with cancer and 9.5 million die from the disease. With this comes to a desperate need of adequate palliative care to support the patient and their caregivers throughout the cancer treatment and through survivorship and end of the life care. The estimated need for palliative care for the cancer patient is 1.5 per thousand population to 43.1 per thousand population. Dr. R. Rajgopal, who was born on 23rd September 1947, is an Indian palliative care physician, anesthesiologist, and professor referred to as father of palliative care in India, in the honor of his significant contribution to the palliative care scene in India. Palliative care in ICU aims to ease the suffering of patients and their families. So, with this introduction, I would like to invite Dr. Ayush Garg, who is specialized, he was taken training in this palliative care also. He is Associate Professor, SRMS Bareilly. He did his MD radiotherapy from SRMS, CCE, PC, Indian Association of Palliative Care 2018, Clinical Fellow, Royal Marsden Hospital, NHS Trust Foundation, London 2022. His area of interest is mainly head and neck, gynec cancer, breast cancer, brain, and palliative care. He has got many honors and awards. He has got first prize quiz competition in Redong Conclave National Meet in 2021, AROI Overseas Fellowship under 35 years of category in 2019, travel grant from Astro Meet Asia 2019, Singapore 2019. He has won many papers and he has won many prizes. Got the chairman's special appreciation. This is recent achievement. Chairman's special appreciation and best faculty award in assistant professor category, academic year 21-22 for the patient's care, academics, and research work, and valued contribution towards the development of institute on the occasion of 20th Foundation Day at SRMS Bareilly. He was also awarded with Young Changemaker Award 40 under 40 category in the Young Changemaker Summit and Award 2022. He has got many publications. So today I have invited him to give a talk on role of palliative care in ICU for the cancer patients. Dr. Ayush Garg, please. Dr. Ayush Garg for his presentation.
So very good evening to all, and very thanks to esteemed faculties for inviting me for this webinar today and giving a talk of an interesting topic regarding role of ICU admission in cancer patients. How much and when is the word that we should think appropriate for our cancer patients. So cancer is one of the major causes of morbidity and mortality worldwide. And around 2 to 3 decades back, in the 20th century was starting, the American College stated that patients with hematological or metastatic malignancies are poor candidates for ICU admission. And mortality rates at that time were more than 90%. Thus, the ICU refusal of these patients was common. So usually they don't used to admit because of the such high rates of mortality. But this scenario has changed in past 25 years with the breakthrough of many new anti-cancer therapies and organ support methods. So earlier diagnosis, intensive chemotherapy regimes, and new targeted agents have shown better prognosis and high cancer cure rates. But such which has helped us in giving an aggressive treatment. Therefore, we have seen more drug-related organ toxicities and increased susceptibility to infection. Therefore, ICU support during the course of disease has increased in a better way in the last 20 to 25 years of time. So, what are the prognostic factors which mainly decide whether we should take any patient for mechanical ventilation or not? So, patients who require mechanical ventilation and need a flow vasopressor more than 4 hours, so they tend to have poor prognosis. Mortality rate is more than 60% when there are 2 or more organs fail, and more than 100% when more than 4 organs are involved. And common apart from respiratory, the other common areas that predict mortality are like is the patient has land up into renal failure, septic shock, or maybe hepatic failure. So these are the major organs in which there is some kind of problem or there is some kind of issues, so which may increase the mortality of the patient in the ICU. And rates of death due to these things have really increased, ranges from 28 to 60%. So the predictors of mortality in critically ill adult patients with cancer. So there are factors patient related or disease related. The patient related factors may be like if there is a low performance status, calcium morbidity index is 3 to 4, and hematopoietic cell transplant specific comorbidity index of more than equal to 2. And disease related factors may be like if the patient is not responding to chemotherapy, if it is a stage 4 cancer, if cancer has relapsed after an initial response, if there is a progressive or recurrent disease, if there is malignant infiltration of vital organs or the airway like bronchus or kidney or liver. So poor marrow recovery post hematopoietic cell transplant. So if there is a poor marrow recovery, then it may suggest bad prognosis and ultimately mortality for the patients. Active graft versus host disease. So trends in mortality in the ill patients during the past 2 decades have shown that patients who have with hematostem cell transplant and without hematostem cell transplant. So improvement in prognosis for cancer patients, the three major factors which I discussed in the introduction as well, the advances in the treatment. These include availability of new drugs, intensified treatment protocols, and improvement of supportive care. For example, rituximab was introduced for non-Hodgkin lymphoma, imatinib was introduced for CML, and thalidomide and bortezomib in multiple myeloma. So these drugs have changed the scenario. Secondly, improvement in diagnostic and therapeutic strategies. So early and aggressive management of septic shock have led to decreased mortality in both cancer and non-cancer patients. So in previous times, the diagnostic therapies were not really good. So with the advent of many new technologies, new state-of-art facilities, so there have been improvement in these diagnostic and therapeutic strategies. And thirdly, to identify patients who are likely to benefit from ICU admission and to improve the triage of cancer patients. So, what are the basic objectives of ICU management? What we should think before sending a patient to ICU? Patient presenting potentially reversible failure of one or more organs, like for example, sepsis. So, sepsis we know it is a reversible condition, and we may pull back the patient from the ICU to the ward. Patient may be at risk of failure of one or more organs with limited or unsuitable conditions for adequate surveillance in conventional ward. So we may prophylactically a patient like who has underwent stem cell transplant. So he may require HEPA chamber type of ward or room. So those for those patients we can prophylactically keep them in ICU. And to achieve transfer back to ward or discharge from hospital with acceptable quality of life. So quality of life is very important because suppose the patient went into morbidity like paralysis and so when we are happy, oh, the patient is alive. But that is not the thing. So with acceptable quality of life should be our objective. And to restart cancer therapy. So suppose the patient went into febrile neutropenia due to aggressive therapy. So we keep the patient in ICU under observation. And once the patient is fine, then we may restart our oncology treatment. So what are the indications of for admission? So first and most important is patient autonomy. So personal and family decisions regarding the decision to be admitted to the ICU and limit the treatment in the ICU. Communication with the patient and family regarding all treatment options to decide from curative to palliative. So it is the duty of the patient and the families to decide. For sometimes patient may come in an unconscious state, so patient may not be able to decide. So attendants, family, caregivers, we need to take them into confidence. We need to have a good communication with them regarding our further management of what we are thinking. These are the four pillars of assessment. First is patient and the characteristics, type of stage cancer, reason for admission, and level of therapeutic effort. How much effort we should give for patient in ICU. So first we'll be discussing regarding patient and the characteristics. So that should influence patient, that should not influence admission or age. So recently the critical care guidelines have shown that even if the patient is more than 80 years, that should not be the only criteria. We have to see what if the patient has any comorbidities, what is the physical functional status, what is the severity of process. So previously the age was the only criteria that or we used to think, okay, it is 80 years, so what is the need for ICU? But now it is way beyond that. Neutropenia, so as you all know, neutropenia is a reversible condition. We can give good antibiotic support, good GCSS support, and patient may revert back into normal mode. So, and other factors like previous quality of life. If patient had a better previous quality of life of patient and a poor performance status. So that should not influence the admission. So overall, we have to see the patient condition. So type and stage of cancer. So for example, so type cancer patients are extremely heterogeneous. So it is not that it is the all the patients will go through one line of treatment. So provided there are therapeutic options, the failure of any treatment line should not be a reason to refuse admission. So suppose in CA ovary, so we have very good options of about fifth, sixth lines of treatment. So in those options we need to see, and we cannot refuse just because first line has failed, so patient is not a good candidate for admission. Tumor progression without treatment options associated with poor prognosis. So what are the reasons for admission? So indications discussed. So again, like cancer related, so usually post-operative care patient, when patient is shifted from after surgery, any oncology surgery, so it may be shifted to ICU for observation. Multi-organ involvement, pulmonary emboli, treatment-related factors like acute respiratory failure, which is requiring ventilation, sepsis, and cardiac complications requiring vasopressor support. Comorbid illnesses like neurological disorders, acute kidney function, or maybe patient is requiring a hemodialysis, or emergencies like tumor lysis syndrome is usually we see in lymphoma or leukostasis, superior vena cava syndrome in lung malignancies, cardiac tamponade, or any paraneoplastic syndromes like hypercalcemia or SIADH. So patients who does not require ICU care are like if we see any electrolyte disturbances, usually in terms of paraneoplastic syndromes, or there's acute area obstruction, so we may be requiring maybe pleural tapping or something, or hemoptysis, adverse reactions to medication or blood products, or mucositis. Until they are very severe, they do not require ICU. Whereas who require ICU care are active graft versus host disease, who have undergone stem cell transplant, diffuse alveolar hemorrhage, hypertension if it is uncontrolled, or veno-occlusive disease of the liver. The final is the level of therapeutic effort, how much effort we should give. So this is a very beautiful chart in which green part from the bottom we see it is a full code ICU management. Second is ICU trial, that we may give an ICU trial that we are anticipating that patient may recover and things may get all right. And third, fourth are like exceptional ICU admission or heroic ICU admission, where we are thinking that maybe there is some kind of benefit. Or finally, in terminal patient, that whether we should do early ICU admission, palliative, prophylactic, what should be there. So that is just a small tip of the like an iceberg. So what does full code management? This would be treatment with curative intent and without restrictions, similarly to any other critical illness. ICU trial, in which we are giving a trial like ICU management with full code status for a limited period of time, where we are seeing we are anticipating patient may get recovery. No ICU admission and no intensive care treatment. So no indication of admission or use of intensive care therapy such as renal clearance techniques or non-invasive ventilation. So prophylactic may be for high risk patients, example, patient risk of tumor lysis or acute respiratory failure. So those patients we can prophylactically for 1 or 2 days or maybe 3 days, we can shift the patient for ICU. Palliative ICU admission for optimizing medical care with non-invasive strategies like non-invasive ventilation, vasopressors without invasive who require continuous monitoring, electrical cardioversion, pneumothorax decompression, or optimizing pain relief. So maybe when our continuous monitoring is required, which is not possible in general wards. So for that, we can keep patient for ICU support. So relevance of intensive care in cancer patients. So usually patients with poor PS3, 4 are not eligible for further anti-cancer therapy. Who are dying patients or those rejecting critical care, where life expectancy is less than 6 months. So the bottom line is that such patients should not be admitted to ICU. So it is a clear-cut message that such kind of cancer patients who have these conditions should not be admitted to ICU just because we are wasting the resources, we are prolonging the illness or maybe prolonging the death of the patient, and other socioeconomic factors which play into consideration while shifting such kind of patient to ICU. In addition, the cost to the patient in human terms should not be overlooked, which is a very important factor in terms of psychological counseling to the attendants. Because cost is just a mere thing, but the human terms should not be overlooked. We should have their feelings, what they are thinking, we should explain them. As a patient admitted to the ICU may be separated to family for an undetermined duration. So he doesn't know who is coming, who is going. He's seeing someone is dying there, someone is coming, someone is going. So he is separated from from the family. So may find themselves in a clinical state that precludes communication of any sort. So either they are not talking, or maybe they are sedated with mechanical ventilation. So it is a condition that is not suitable for such kind of patients. So early palliative and end of life discussions by the intensivist and the oncologist should be a major point of discussion. Patients with grim prognosis, patients who do not progress toward recovery in the first several days of ICU care. So usually we tell the patient that maybe 24 to 48 hours we'll come to know what kind of response the patient is showing. So patients for whom symptom palliation would improve the quality of life. So maybe, but we have to discuss with the ICU consultant. So when we should discharge such patient from ICU? When they are physiologically stable and do not require monitoring. Whenever possible, especially with frail patients, counsel the caregivers about the progress, treatment, and home care. And this could reduce the frequency of readmissions in further subsequent visits. So consistent predictors of poor outcome associated with sepsis in adult patients with cancer include the following. Pulmonary site infections, a patient may be sepsis due to pulmonary infection. It has been identified as an independent predictor of death at 28 days in a retrospective study. Fungal infection, which is quite common, aspergillosis, or other predictors which include polymicrobial infections and carbapenem-resistant gram-negative bacteria. But still, there are many unanswered questions which need continuous discussion, research, since palliative care is very undermined area and not a very good thing. So people tend to have less research in these areas. But still, the questions are establishing long-term outcomes in oncology patients who survive the ICU stay. Do we prolong the dying process, or do we actually increase the survival? We don't know. So addressing qualitative outcomes, what we are achieving, searching for specific family needs and communication strategies. There is nothing specific, but yes, I'll suggest that the Indian Association of Palliative Care is giving a great opportunity to understand all these factors. Evaluating new admission policies, which patient should be admitted, which patient should be refused, improving transition from curative to palliative care, evaluating the impact of ICU on overall long-term and disease-free survival, defining the appropriate timing for ICU admissions, avoiding delays, like we are talking about prophylactic admission in tumor lysis syndrome. So whether we should prophylactically admit or we should wait for it to happen, appraising prognostic factors of mortality, evaluating outcomes in patients who receive intensive care like NIV support, vasopressor in the wards. So is it really can be done in the wards, or performing qualitative studies before any recommendation with use of NIV as the ceiling of therapy. So in the conclusion, I would like to say in patients with cancer who require ICU admission, the survival rates have improved markedly. ICU admission is discouraged in uncontrolled malignancies and in bed-ridden patients who have poor performance status with no therapeutic option for treatment. Good cooperation and communication between the oncologist and intensivist is the cornerstone for such cases, and the same should be discussed with the family and the caregivers so that we can come to a mutual consent what to do, what is the best for the patient, when to move out of the ICU. Because it's quite a tough decision when the patient is on mechanical ventilation and the attendants are asked that there is no response. So if they are taking home, that means they have to accept the reality what will be they have to tell to the society, to the relatives, because everyone is like, the patient is on ventilator, why you bringing home, you don't look after them, you don't care for them. So but eventually the person who is the son, daughter, father, brother, sister, mother, so they know what actually the patient is going through. They don't understand, the world doesn't understand what the patient is suffering through, and increasing the suffering for such type of patients in ICU is, I don't think, is worth it. And a multidisciplinary approach is always required, multiple teams of a nephrologist, neurologist, cardiologist, nutritionist, physiotherapist. So everyone is required for a good ICU care. So in general, if it's a good life expectancy, we should go ahead with full code of ICU management. If we see in the inaugural, like in a primary setting, there's a poor life expectancy, ICU trial may begin for such kind of patients. After the failing of first line therapy, we have good life expectancy, ICU trial may be given, but in poor life expectancy, we should discourage any kind of mechanical ventilation. Even after second line therapy, we have a good life expectancy. Exceptional ICU may be tried where within 24 to 48 hours, we can just tell the patient what is the current scenario. And in poor life expectancy, we should definitely discourage mechanical ventilation. In cases of relapse or refractory end-stage diseases, we should never counsel or advise patients for ICU care, and we should definitely discourage mechanical ventilation. Thank you.
Thank you, Dr. Ayush. And Doctor was busy with some operation going in the OT, so he had to leave. Excuse me for that. And yes, Momita, are there any questions?
Yes, ma'am.
The chat box?
Yes, ma'am. I have received a question. I'm putting it in the chat box.
Okay. Can you tell the objectives again? Is that the one? From Dr.
ma'am.
Ramya Vardhani Mamidala. Yes, please. Dr. Ayush?
Yeah.
Yeah, please.
So
answer.
basically, so objectives is like if we are anticipating that it is a reversible condition. So for example, I said that suppose the patient is in sepsis or who has landed in febrile neutropenia. So we know that patient this is a reversible condition, and we may if we give good
We may
antibiotic
benefit
support,
from
good
that.
disease. Yes. So in such case, or maybe the patient who is at risk of failure of one or more organs, where we are anticipating that patient may land up into renal failure because patient is 75 years old,
Yeah.
body is working at the threshold value. So in such cases, we are anticipating that maybe patient may land up in renal failure. So we may transfer the patient to ICU for immediate care, or when we are shifting back with good quality of life, at the end what matters is good quality of life. So if we are as I said that if the patient is like in the we are sending back from ICU to ward in a debilitated condition or in a paralytic condition, so that is not the achievement of ICU, or that is not what we want. So if we know that there will be a good acceptable quality of life, in such case only we should shift patient to ICU. Or lastly is like when we have to be like febrile neutropenia, we know that after it is resolved, we can again continue with our therapy with our radical management. So in such cases, we should shift the patient
Yeah.
to ICU.
Fever is okay, but neutropenia for that.
Yes.
But
Yeah.
for that, we are giving all that, no? Filcad and
GCSS
all
support, yes, we give filgrastim,
that
but
same.
sometimes patient land up like in tumor lysis, or patient land up in severe neutropenia. So if patient is not able to tolerate, so in such cases, uh, when we are
Maybe,
anticipating that it is a
maybe.
reversible condition, so
Yeah,
for
as
such
you have
cases,
told earlier, that maybe we are prolonging the life or
yeah,
maybe not,
yeah,
but we should give
yes,
for improving the condition of the patient.
yeah.
Yeah. What would be your take-home message for all who are listening to us?
The bottom line, which I would like to highlight with this whole seminar, is only one thing: if the patient has a poor performance status, where we know that patient will not improve, patient is stage 4, patient is
Terminal,
terminal stage, life expectancy is very bad, less than 6 months, such patient should not even be counseled for ICU. It is
right.
rather than admitting, they should not be given an option to patient to be in ICU, because we won't achieve anything. We would be just prolonging the death or maybe the suffering of the patient. So
Absolutely.
it is better that patient is with their near and dear
Left.
ones in the family. So
Yes.
he maybe patient is not responding, but he is hearing somewhere, and he is happy that he is among his family rather than in an unknown place when unknown people are touching him everywhere. He may have lived a life with very dignity, but at the end of the life, all the dignity is drained if such patient is subjected to ICU. So bottom line is such patient should not be entertained, not be given an option for ICU admission.
So what do you say in renal failure? Suppose patient has landed in renal failure. Should we admit him or not? Because then he needs dialysis and other things. We should admit him before renal failure, I think so. In which we think that maybe renal failure may occur due to chemotherapeutic
Yeah,
drugs.
exactly, exactly.
But after renal failure, no point.
No,
Here is the role of palliative care.
palliative care. Yes.
So this, all the listeners, all our participants should understand that it is for talking about the cancer patients and not about the general, in
Yeah.
which even a heart patient and other diseases, till the last stage, till the death, you all admit in ICU.
Yeah. Yeah.
So here it is just for improvement, and
Yeah.
otherwise you don't require in the terminal cases.
Yeah.
That is the bottom line.
Yeah.
Thank you, Dr. Ayush Garg.
Thank you, ma'am. Thank
And
you.
so kind of you for such an elaborate and crisp and informative talk on this very important topic, which is always left behind in oncology.
Yes.
Thank you so
So
much.
that is a very neglected topic. So
Neglected
no one
topic,
talks
yeah.
about palliative
Yes,
care.
this
So
aspect.
yes.
Okay, thank you so much for
Thank you.
accepting our
Thank
invite
you.
and
And
briefing us in such a short time and being so crisp. So thank you all the audiences who have listened to us and have been participant. Thank you the Clirnet team
Thank you
for
so
your
much, ma'am.
software support.
Thank you so much, ma'am, for giving us this opportunity to host this session. And thank you to all of you. So, ma'am, now with all your permission, I'm closing the session here for today. And
Okay,
looking
thank
forward
you.
to listening. Thank you so much.
Thank you so much.